All right, we will go ahead and get started. Good day, everyone. Bonjour à tous. Welcome to this World TB Day webinar. Bienvenue à ce webinaire à l'occasion de la Journée mondiale de la tuberculose. Si vous voulez écouter en français, veuillez cliquer sur le globe terrestre en bas de votre écran et sélectionner français. My name is Andrea Monahan. I am the National Program Coordinator for the Tuberculosis Program at the First Nations and Inuit Health Branch at Indigenous Services Canada. I'm joining you virtually today from the traditional and unceded territory of the Algonquin Anishinaabe people, and I acknowledge with gratitude and respect the individuals, families, and communities who have lived here since time immemorial. I invite you to take a moment to reflect on the First Nations, Inuit, and Métis people who originally lived on the territory you're joining from today. Before we get started, I will go over a few housekeeping points to help us have a smooth webinar. We will share a poll at the beginning and end of the webinar to help us evaluate our webinar. It will pop up on your screen momentarily, and I invite you to complete it as I'm running through these housekeeping items. So Cynthia, you can go ahead and launch the poll. Everyone is currently muted and should remain muted for the duration of the webinar. If interference is heard from an unmuted mic, we will mute it. At the bottom of the screen, you will find a chat option. Here you can reach out if you need assistance with a technical issue or pose a question for our presenters. My colleague, Montana Massicott, will monitor the chat. After the presentations, there will be a question and answer period. We invite you to write your questions in the chat box or raise your hand. If you're joining us from a phone line, you can enter *9 to figuratively raise your hand, and we will prompt you to unmute your line to ask your question. If you are listening in French and wish to follow on the French slides, you can find them in the chat or in the meeting invitation. And lastly, this webinar is being recorded in both English and French for later viewing. And I'd like to extend my thanks to our colleagues at the National Collaborating Center for Infectious Diseases who've offered to host the recording on their website and their YouTube channel. That takes care of our housekeeping items. To start this webinar off in a good way, I will invite our elder, Sequalia, to provide some opening remarks. And after Sequalia speaks, I'll invite Dr. Wong to say a few words of welcome. Cynthia, I'll ask you to end the webinar, please. Or sorry, not the webinar, the poll. And Sequalia, we welcome you.
Hi, Austin. I welcome each and every one of you to the ancestral traditional territories of the Squamish Squamish Nation, where you're zooming into on my iPad. And I welcome and acknowledge the ancestral traditional territories where you live, work, and play, and also acknowledge all the traditional First Nations peoples who are part of the gathering today in your nations and your territories. I raise my hands to each and every one of you in thanks, as we do in the Coast Salish tradition. This means welcome, and it also means thank you. So Check Quen Mentomi up. We're grateful and thankful to you for joining today. I'm Sequalia Quashaman Sna, that's my ancestral name, and Wanik is my name on my ID and everyday name. And I go by Sequalia probably for the last 43, 45 years now of my life. And so if you call me Anne, I probably won't respond. If you say Sequalia, then I will. It's just the way I've been the last while. And I wanted to share with all of you that my late grandfather helped raise me, my grandparents, and one of the teachings he gave me of our Coast Salish way and I learned also from our elders is that each and every person has an inner energy, and that inner energy is within us. He said when I was like 10, 11 years old, he said, it's like how the Chinese say yin and yang. It's constantly moving and it's in us. And if we believe in it, it can help us emotionally, mentally, physically, and spiritually. And he said this inner energy connects us to everything in the air, earth, water, and to each other. And, you know, that's why we can send prayers to our family wherever they are in the world. And that's why I share on Facebook. I believe this is a understanding of all our nations, because on Facebook, people say prayer warriors, send prayers for my child or parents or grandparents or aunt and uncle. And all of us who believe in that power of prayer, spiritual prayer, not religion dictated prayer, although many follow both, start praying and send our energy. And then those people come on and say, thank you, prayer warriors. The prayers helped. And so I always share that teaching, and I say that when my children were young and I saw the first Star Wars with them, and Obi-Wan and Luke escaped from the planet they were on with Han and Chewie on the Millennium Falcon, and Luke said, I want my father's lightsaber and learn the ways of the Force. And then Obi-Wan starts teaching him about the Force and says, the Force is in all of us. It connects us to everything there is in creation and to each other. And it can help us. And when I heard that, I got excited in the theater and said, that's what your great grandpa taught me. That's what great grandpa taught. That's our teaching, our belief. And my children were like, shh, because we were in the theater, and I was saying, but that's our teaching. This is awesome. And so I became a Star Wars fan. And because it has teachings sometimes within the different shows that are beliefs of Indigenous people. And I share this to make you have a little laugh and also understand teachings are important. And, you know, I know that the person who did that show investigated Indigenous beliefs of energy and force when he did the story. And so sharing that and getting you to relax, let's do Tai Chi yoga exercise. And I tease and say, you're going to do the downward dog, and that's to make you relax more, because I want you to open your hands and put them either in your lap or on your chair, arms of your chair, or on your desk, open. Don't be like this or this or this. That blocks your energy from sending and receiving to each other. And that's a belief. You need to be open to receive and not block your inner energy, and let others send to each other. And you can send messages with mind when you believe in it enough and you're connected to certain family and friends. And so open the energy. And while I pray with me. I'm a spiritual person and believe in that power of prayer. I wasn't raised in the church ways, and I respect the church because my grandfather told me to respect it, and all ways that are different than ours, to respect it and follow it. And we're going to for pray for each other, your family, friends, and community. Chenkwa mentomi kakakanak chasiam, yon so tinoy up in man squalwin to squal's deceits, asking you, Creator, to watch over all your children gathered here today and help them with their squalwin, the feelings in their hearts and minds. Squalwin is hearts and minds. It's a real strong emotion and word that can't even be expressed. So asking you, Creator, to help all your children squalwin and help guide them and protect them. Asking you, Creator, to help all your children gathered here today to come together in Chomot and Squalwin with one heart and one mind to be able to Chen Chen Dwight stand and work together to hold each other up and support one another and be able to share, transfer knowledge, experiences, and ask questions and be able to create solutions for the present and future. And always learning from the past and what happened within the First Nation communities with the TB hospitals that existed and how it impacted our people and why we fear the hospitals and doctors in some cases. So asking everyone to come together and learn from the past, present, for the future. And asking the Creator to let today be a yet one halt up, an excellent work today. And that we can share all our different views, as I said. Tama Quitsi Snachum. Those are my words. Chen Quinn Mentomi. Andrea, I'll now turn it back over to you.
Thank you so much, Sequoia. And I'll invite Dr. Wong to join and say a few words.
Miigwech, Elder Sequoia, for opening this event and for being with us as we talk about the importance of offering culturally safe care to Indigenous peoples across this land, Indigenous peoples being affected disproportionately by TB. My name is Tom Wong. I'm the Chief Medical Officer for Public Health at Indigenous Services Canada. It is my great pleasure to welcome everyone today. Let's take a moment to reflect upon the strengths and experience of the First Nations, Inuit, and Métis peoples who have inhabited this land we are on today since time immemorial. I'd like to also welcome and thank our presenters today for sharing their experience and knowledge on culturally safe TB care. While Canada has one of the lowest TB rates in the world, this disease continues to disproportionately impact Indigenous peoples. This is largely due to the continued impact of colonization in Indigenous communities, including the historical trauma of TB management and longstanding inequities in socioeconomic conditions. The 8th edition of the Canadian TB Standards was released last year on World TB Day. Chapter 12 was a much anticipated and welcome new addition to the TB Standards. The writing was co-led by representatives from First Nations, Inuit, and Métis organizations. It is distinctions-based. It recognizes the unique history and experiences with TB among First Nations, Inuit, and Métis peoples. And it continues the complex historical and continuing impacts of colonization on health status and TB today. As such, it is an important part of the path towards both reconciliation and elimination of TB in Canada. I encourage all health workers caring for Indigenous peoples to continue to take steps to improve cultural competency and to learn about how historic events continue to impact the health of Indigenous peoples today. Cultural competency is a continuous journey and part of a lifelong learning, not just today, it's every day. It needs to be front and center in our daily work. Miigwech, Nakumik, and merci merci, and thank you, Elder, Sequelia, and to our presenters, all of our presenters today, and to each participant who has made the important decision to be with all of us here today. Back over to you, Andrea.
Thank you very much, Dr. Wong. Thank you for joining us today, and thanks for sharing those words. I noticed in the chat that that many people had difficulty accessing the poll and completing the poll, so I am going to relaunch it now. There are 5 questions, and you will just have to scroll down to see all 5 questions. Right. I'd now like to welcome Kelsey McGregor of the Assembly of First Nations, and a last-minute addition to our schedule, Dr. Alex Petitquan of Inuit Taparit Kanatami, who is replacing Raymond Obed, who was unfortunately unable to be with us today. Kelsey McGregor is an Anishinaabe from Whitefish River First Nation on the north shore of Lake Huron, is from the Crane clan. Kelsey received a BA in Psychology and Health Sciences in 2019, then a Master of Public Health from Western University in 2020. Prior to joining the Assembly of First Nations health sector as a policy analyst, she worked at the community level within First Nations health research, health promotion and prevention, and policy. Dr. Alex Petitquan is Anishinaabe from Wabauskang First Nation and graduated from the Northern Ontario School of Medicine in Thunder Bay, Ontario. His work during his pathology residency before joining the federal government included evaluating medical devices as part of an Ontario Centres of Excellence grant on remote pathology solutions. He now works as a senior analyst in the federal sector, which has spanned Indigenous public health, epidemiology, data sharing agreements, regional Indigenous community engagements, and participating in joint departmental public health response for emerging issues and COVID-19. His personal work has spanned First Nation governance, health policy, and he sits as a member of the Health Expert Advisory Panel for Grand Council Treaty No. 3 in Northwest Ontario. Dr. Petitquan currently works at Inuit Taparit Kanatami, the national representational body for Inuit in Canada, leading the public health and tuberculosis files. Kelsey and Alex, welcome today. I will share your presentation.
Yeah, awesome. So thank you so much, Andrea, for the introduction. So yeah, thank you, everyone. I'm so honored to be here in recognition of World TB Day. So in addition to myself from the Assembly of First Nations, I also have Marlene Larocque here as well, who had done the work to develop this chapter as well. So at the end of the presentation, she could take any questions that I don't have the answers to. Yeah, so again, Ani Bojo, Kelsey McGregor, Jagnashi Nozwin, Wigwaskinnagadon Jaba, Nishnabek, and Dow. So hi everyone, my English name's Kelsey McGregor and I'm from Whitefish River First Nation. And I am currently living about 10 minutes away from there. So I'm still pretty close to my original homelands. So it's great to be here. And Alex, would you like to introduce yourself quickly or would you like to just go into it?
Sure, I'll just do a quick introduction. Bonjour, je m'appelle Alexandre Coco Petitquan, je me viens de Northwest Ontario. Ma première nation est Wabauskang from Grand Council Treaty 3. Very happy to be here and presenting on a very important day on World TB Day, given the current status of TB for Inuit as well as for Indigenous people across Canada, and really happy to present on this very important chapter, which is a milestone in collaboration and working together between the national Indigenous organizations, as well as with our colleagues from the Canadian Thoracic Society, as well as researchers and others that contributed to the chapter. So I do want to send a shout out to my colleague, Deborah Van Dyke, who's no longer with ITK, but had contributed greatly to this chapter. And so I'm here in her steed as well as in Raymond's steed for presenting here for the chapter. Miigwech.
Yeah, awesome. If you'd like to go to the next slide. Perfect. Yeah. So just a little outline of what we're going to go over today. So the first thing we're going to talk about is the epidemiology of the tuberculosis rates across the 3 Indigenous groups in Canada. After that, we'll look specifically into the First Nations and Inuit experience with tuberculosis. After that, we'll highlight the work that was done by the Canadian TB Standards Indigenous Chapter Committee and how this chapter and its work came to be. And then we'll underscore the 7 good practice statements that had come out of this work. So next slide, please. Perfect. So I'll just go into the First Nations. So currently there are just under 1 million First Nations people in Canada. That's speaking to status Indians or people who are registered under the Indian Act. So those are under. So this number may be smaller than what is actually what's in reality. And so the majority of the First Nations people actually off reserve in rural or urban areas, or they're living on one of this over 600 reserves across the country. And so the current rate for First Nations for TB in Canada is about 37.6 times higher than the Canadian-born non-Indigenous population. Would you like to go ahead, Alex?
Sure. Thank you, Kelsey. Me whichever one. So there are currently 70,000 Inuit in Canada, of course, the majority of which live within Inuit-Nunagat, the Inuit homeland. It encompasses 51 communities across the Inuit settlement regions, including Northwest Territories, Nunavut, Nunavik, which is in northern Quebec, as well as within Nunatsiavut, which is located in northern Labrador. Inuit-Nunagat, which is the land base, makes up about 40% of Canada's land area and 70% of its coastline. Now, when it comes to the active rate of TB, of course, the pandemic has shown some interesting fluctuations in the amount of rates, but the last reported rate was at least 300 times, but between around 300 to 400 times the rate of the Canadian-born non-Indigenous population. And I'll chat a little bit more about that later on in the presentation. And back to you, Kelsey.
Yeah, and then finally for the Métis, so there are just over 500,000 Métis in Canada, and the majority live in Ontario and the Western provinces. And so the active rate for TB among the Métis population is about 7 times the rate compared to the Canadian non-Indigenous population. And so altogether, the Indigenous people in Canada make up just under 5% of the Canadian population, but in TB cases, they make up about 20%. And so this is compared, so while the majority of cases are in the foreign-born population. And so the majority of Canadian-born Indigenous comes from the Indigenous population. Apologies. Next slide, please. Yeah, so next we'll go into the historical experience of tuberculosis, first with First Nations people. And so looking at pre-contact, so before settlers came to what is now the Americas and Canada, First Nations people had their own established governmental laws, systems, diplomatic relationships, customs and languages. And many of those customs practice environmental sustainability and wellness. And so it's at this point in time that TB did exist in the Americas, but cases were sporadic. Going next to post-contact, so from when settlers arrived to about the late 1800s, in the beginning there is this nation-to-nation diplomacy, there's economic trade, but over time there's a deterioration of respect for Indigenous peoples and First Nations for their cultures and their languages. Over time, there's more land encroachment, overexploitation of the land and natural resources. And after this contact, it's TB, there was more TB exposure and the introduction of more virulent strains. And then looking from the late 1800s on, we see First Nations go from allies of the country to wards. So this is when the treaties and Indian Act are first put into place. They abolish our governmental systems, language and practices, make them illegal. We are forced onto reservations, encampments, there's indoctrination and a lot of food insecurity. And so it's at this point when there's a lot of that governmental interference, the TB cases surge and there are many countless deaths. Next slide, please. And so it's at this point in time as well that we see residential schools and sanitary treatment in Indian hospitals be put into place. And so many of these institutions had very poor infrastructure, they're overcrowded, poor ventilation, there's very poor, if any, medical treatment, malnutrition, food insecurity, and lots of trauma and abuse. And many of these people who had to attend these institutions were forced from their homes very far away. And so it's in the residential schools, it's estimated that a quarter of the students had died from TB alone. And then the treatment from all these institutions allowed for harbored resentment, suspicion, and distrust towards the government and medical systems. And it's not that these governments didn't know what was happening. We see this paper in the middle of the slide here by a chief medical officer, Bryce, who had written at the time, linking the poor infrastructure and treatment in these institutions to the poor health outcomes and deaths, but the paper was largely ignored by those in power. Next slide, please. There you go, perfect. And so now going to more current history. So in the 20th century, mid 20th century, First Nations TB deaths and cases tend to actually decrease. So this was coinciding with better medical technology, better diagnostic tools, better treatments, vaccines. And it wasn't only the medical advancements, it also coincided with amendments to the Indian Acts, which allowed First Nations people to legally practice their culture, participate in the legal system, vote in federal elections, and removed compulsory enfranchisement. And then going to today, First Nations TB cases have remained stagnant over the last couple of years. And so it's evident through the history that at the height of the Canada's racist legislation against First Nations people is when our TB rates were the most devastating. And as we slowly begin our path to reconciliation, TB still remains an indicator that colonialism is still present. And I think next is Alex's turn for the Inuit experience. Thank you.
Thank you, Kelsey. So I do want to start a little bit with Nani Lavut, but before I do that, I'll just mention that between 2015 and 2019, the reported incidence rate of active TB disease amongst Inuit living in Inuit was over 300 times the rate of Canadian non-Indigenous people. Now, what's interesting in this rate, this is only attributing to the active TB rate and doesn't take into consideration the latent TB rates, which is very difficult to track in any instance because they hide under the radar and they're identified in surveillance activities. So it may be likely that the rate of LTBI is likely more than obviously the active TB rate of disease. However, recent reporting for active TB among Inuit has shown a decrease of 61% between 2019 and 2020. However, and this is the caveat that I mentioned earlier, that this is considered to be a result of the underreporting due to COVID-19 pandemic and is likely higher than previously reported. We have also been hearing anecdotal reports of individuals presenting very in late stage disease of active TB. And it's not just TB that is experiencing this. We've also seen this in other preventable diseases as well, including heart attacks and other cancers as well. Now, when it comes to the high TB rates, now this is particularly a symptom of the health disparities between Inuit and other Canadians, including overcrowded housing, food insecurity, and barriers to healthcare and poverty. Now, the reason why I bring this up is Nani Lavut is a very important initiative which addresses some of the prior traumas that have been experienced. So ITK collaborates with the land claim organizations on the Nani Lavut initiative. It helps Inuit families locate loved ones who had died of TB away from home between the 1940s and the 1960s. Now, if you're not very familiar with this part of history in Canada, I very much encourage you to read up on it, as there is it really speaks to the current situation and why we're seeing a lot of these health disparities today as well. Now, Nanny Levoot was launched in 2019, once again, to help Inuit families locate their loved ones' grave sites. The same year, the federal government apologized to Inuit for its actions during the tuberculosis epidemic. So Nanny Levoot translates into let's find them in Inuktitut. Now, the initiative is a collaboration between the federal government, ITK, and the 4 Inuit regional Inuit organizations, which each manage their own programs, and ITK provides the regions with support. The Nanny Levoot initiative estimates more than 850 Inuit died while receiving treatment for tuberculosis in southern hospitals and sanatoriums. The Nanny Levoot database contains information on more than 4,500 patients from the period between the 1940s and the 1960s, and additional information is being discovered and added to the database by the regions. Now, it's important to recognize that the history of TB for Inuit is a journey of trauma, loss, rediscovery, and supporting the healing process. Without reconnecting to loved ones with those that were taken, providing closure, the healing and trust in the healthcare system cannot start. While it can be shown that during this time, this was a very clinically driven approach to tuberculosis elimination, and essentially resulted in reduced rates, which were very clearly tracked, but the social cost for Inuit was astronomical. As a result, when this particular TB program ended, rates rose again, having failed to address the impact of colonialism on the Inuit way of being. So this is why I mentioned Nanny Levoot as an important initiative, and it's a key element of tuberculosis elimination. Next slide, please. You can click a couple times forward there. Perfect. So this slide just provides a overview of settler contact and the history of colonialism and interaction between Inuit and the settlers from when settlers first arrived until today. And you can see within, it's divided into various eras, including the arrival of settlers, the government era, which really saw a lot of the detrimental effects of colonialism against Inuit, including the disease epidemics of TB and removal to south, which you'll see in the middle there. And then in the late 60s, you can see that there was a new initiative and political movement began for the Inuit, where they began to reaffirm their independence and their self-determination and governance as well. And you can see some of the land claim agreements that have been signed over the course of that time span. And it's really important to understand the history. When you begin to understand, acknowledge the history that the Inuit had experienced, then you can start providing culturally safe care in a fashion that Inuit can also react to, but then also essentially heal from these experiences. Next slide, please. So once again, going back to the TB rates, I've already mentioned this previously, and you can see that the rates within each region, now this is of course active TB rates. One thing I want to note is the increase of rates as you go from west to east. Now in Inuvialuit, while it says 0, there is a large caseload of latent TB cases that need to be addressed. And the advances so far with rifapentine and 3-HP as a shortened treatment regimen for individuals is a very welcomed initiative. But of course, more work needs to be done when it comes to access to this medication and ensuring that there's adequate supply for everyone in Canada, including Inuit, and ensuring that they have access to it as they need. Next slide, please. Now, these priority areas for action, they differ slightly from what's in the Canadian TB standards in the new edition. However, these are the Inuit-specific priority areas for action. And what's important to note here is while we have this national document of standards, which provides some concrete steps for individuals, provides culturally safe care for distinctions-based groups, but this is what the Inuit have decided as what are their priority actions, which is important in self-determination. It includes enhanced TB care and prevention programming, reduce poverty to improve social determinants of Inuit health, empower and mobilize the community, strengthen TB care and and prevention capacity, develop and implement Inuit-specific solutions, and ensure accountability for TB elimination. And this is not just for the federal government, but also for Inuit as well and ITK. Next slide. All right, now, as I mentioned, the Inuit Tuberculosis Elimination Framework was developed in 2018, and the government of Canada had initially invested 27.5 million towards TB elimination action plans specific to each region of the 4 regions that make up Inuit Nunavut. This work includes TB screening activities, community outreach, training community health workers, Inuit-specific research and examination of the cross-section between TB and COVID-19. Now, of course, COVID-19 came up after the framework was released, but this was an added element, seeing the impact of an additional respiratory disease that had the same public health principles applied to it. So now we're starting to look at what was the interaction between COVID-19 and TB, and what were the results of that, both on the impact of TBE activities. Now, ITK's work has focused primarily on advocacy work to improve social and economic conditions necessary for healthy TB-free communities, but there are specific activities including confronting the gaps in social determinants of Inuit health. I mentioned again, housing, food security, nutrition, mental wellness, equitable and cultural relevant education, and access to culturally safe services, which have perpetuated in TB Inuit communities. Now, addressing the social and economic infrastructure gaps through major new investments in infrastructure will help to accelerate the distribution of resources required to close the infrastructure gap and uphold Canada's human rights obligations. Now, poverty reduction through development of a model of basic income in partnership with Inuit, which would target those living around and below poverty line established during regional and community cost of living and income indicators. It is important to note that TB is more than just a bacterial disease. It is a disease that is perpetuated by social inequities. For this reason, you can see that there are other frameworks that coincide and address the social determinants of health, and most importantly, housing and food security. Alone, only one issue is being addressed. Together, there is a holistic approach to TB elimination, which heals not just the disease, but the social inequities that perpetuates its continued existence in Inuit Nunavut. Perfect. And ITK contributed to this chapter in the new tuberculosis TB standards. And from the Inuit perspective, this serves as an introductory guide to tuberculosis care to improve cultural competence for healthcare workers and public health professionals serving Indigenous peoples in Canada. And we're very happy to be a part of this very important initiative. And I'll hand it back to my colleague, Kelsey.
Yeah, so the Canadian TB Standards is a healthcare resource that is revised every few years. And so in anticipation in writing the 8th edition, the contributors wanted to hear from Indigenous peoples, Indigenous organizations, to hear what their priorities were. And so one of the biggest changes was there was a change from rather a biomedical and clinical perspective on tuberculosis and how to prevent, treat for, and care tuberculosis. It looked at the priorities that the Indigenous groups voice. So looking at those more social determinants and things that like Alex had said, exacerbate tuberculosis, not necessarily the cause. So next slide, please. And so from the onset, the Indigenous organizations that were involved, AFN, ITK, and Métis National Council, they voiced that the context, specifically the historical, cultural, epidemiology of each Indigenous group, is essential to being able to understand and care for individuals with TB, as TB care does not stop after the prescription's written. So just because we give someone the medicine or the vaccine doesn't mean they don't go home back to the conditions that had caused the case in the first place. And so in writing this chapter, with these with the overarching cultural awareness and safety. There's the composition of these 7 guiding principles that healthcare workers should be taking into consideration when they're working with Indigenous people in TB care. Next slide, please. So these are the 7 good practice statements. So I'll go through them fairly quickly. So number 1 is for healthcare professionals to educate themselves about the epidemiology of TB in the community, recognizing the community's historical relationship with TB, and to help contextualize current day care. So it's not enough to know the history of just the Inuit, the First Nations, and the Métis. It's about talking to the community themselves and exactly what they experienced, the people who are still living there today, and what their family and ancestors had experienced themselves. Number 2 is understanding the geography and climate of Indigenous communities, including that many are facing high rates due to isolation, and that healthcare is less accessible and diagnosis and treatment is delayed. Number 3 is acknowledging the territory that's once occupying and working towards understanding, practicing cultural safety by self-reflection on power differentials, respecting cultural differences, including language, and incorporating cultural values to promote a safe and inclusive environment. Next slide, please. Number 4 is recognizing the specific social determinants of health affecting the distinct Indigenous groups, with the aim of delivering quality TB care and closing health equity gaps between Indigenous and non-Indigenous Canadians. Number 5 is acknowledging the role of ongoing colonization, personal and systemic racism, and privilege as a result to health equity and TB care delivery, and take steps to prevent harmful effects. Next slide. Promote self-resiliency, advocacy, and empowerment by respecting the rights of Indigenous people as outlined in the Charter of TB Care and UNDRIP. Number 7 is understanding that each Indigenous group, First Nation, Inuit, Métis, is historically and culturally distinct and may therefore have unique TB needs, and they do have unique needs. Next slide. And so these 7 statements can actually be organized into these 4 categories. So the first 3 is just knowing the community you're working with, knowing their history, what they're currently dealing with, knowing the physical characteristics, knowing maybe what's affecting care, treatment, diagnosis, the physical things of the environment, how easy it is to access care, and just acknowledging the land that you're on and the history of the people. The number 4 and 5 can be categorized as recognizing the invisible barriers that may affect TB, that do affect TB. So the social determinants of health, so overcrowded housing, food insecurity, lower income, things like that. And then having the recognizing colonization as not only something that has created these gaps in social determinants, but as something that is currently ongoing. Number 6 is respecting self-determination and self-resiliency. So having Indigenous groups be active participants in the creation of solutions, and similar to what the Inuit are doing, having solutions that are drove by their people for their people, and having that distinction-based approach. So we do have this national these national priorities, but having distinctions based like the Inuit priorities is incredibly important. Next slide, please. And yeah, so these are just the outlines of priorities for as a whole for this chapter. So there is a need for timely, up-to-date, and reliable data for tracking TB performance indicators. So Alex kind of alluded to with the Inuit data, there is a gap in data. And similar for First Nations is that we don't have up-to-date current data, so we're not sure exactly where we are. So it's difficult to plan where we want to go if we don't know our current issues. The next is the promotion of Indigenous community workforce development to address health human resources shortages. So it's not enough to get people in the community to help with these healthcare shortages. It's about getting Indigenous workers, people from the community who know the community, who can deliver that culturally safe care as well. Another priority is relationship building. After that is call for rifapentine to be submitted to the manufacturer for regulatory approval. So rifapentine is a very effective medication for TB, and currently it's only accessible through very special channels. Another priority is recognizing and addressing the connection between the housing crisis and tuberculosis, and not only the housing crisis, but other social determinants of health. And then finally is the creation of resources for distinctions-based tuberculosis elimination efforts. Next slide, please. And so, yeah, so that's the conclusion of what we went over. So the TB epidemiology for the 3 Indigenous groups, Inuit, Métis, and First Nations. We looked at the historical context for tuberculosis in First Nations and Inuit, briefly went over the TB standards and the 7 good practice statements for TB healthcare, and then outlined the priorities that did come from that work. And next slide, please. And yeah, so just an acknowledgement for all the great people who did the work on this great resource. So all the organizations. And yeah, I believe that's the end of our presentation. And Marlene is here as well, so she could take any questions too. She did help write the resource. So thank you.
Thank you so much, Kelsey and Alex. I see that we are getting some questions already in the chat. I'm going to hold those until the end, if that's all right, just to make sure that we have sufficient time for all of our fantastic presenters, and then we will address any of those questions at the end. Thank you. Our next speaker, I'm very pleased to introduce Aiga Sanguya. Aiga is from Kangay-Tugapik, also known as Clyde River, Nunavut. Aiga is a loved and respected leader in her community, and much of her work has been focused on the connection between health and community. Aiga has been a community health representative for almost 20 years. She started when there were only 300 people in the community, and there are now over 1,200 people in the community. Aiga is trusted by her community to answer questions and maintain confidentiality, and she is trusted and respected by other community health representatives, nurses, and health staff in Nunavut as an experienced advocate for her community and for Inuit. I should say individuals outside and organizations outside of Nunavut as well. Aiga has been on the board of directors for several non-governmental organizations, including Iliasaksivik and the Canadian Aboriginal AIDS Network, which is now known as Communities, Alliances, and Networks. She participated in the Meaning of Ice project, a book about the Inuit relationship with sea ice, and traveled to Alaska and Greenland as part of this project. She is currently working on an Inuit-led research project to address food security, nutrition, and climate change. Aiga values the love and support of her family to take on these projects and is very proud of her children, grandchildren, and community. Aiga Tungasisugi.
Thank you, Andrea. Yes, I am a survivor of TB, although as I work at the health center for many, many years. As Andrea said, that I am the link between the community and the nurses and doctors and the health center. But I had TB myself in 2017 because I worked at the health center. I was denying that I had TB, but when I realized that, you know, I know the history of the people, my people going down south for many years for treatment, TB treatment. They went south. They didn't speak English. They didn't know any other food than our own food. It was a very different experience for those people, and my husband was one of them. When he was a boy, he went down to Toronto sanatorium for TB treatment, and it's for me and him. It is totally different situations that we were at. So just the history first. When my husband, when he was a boy, he was sent down for TB treatment, and it was very different for him because he didn't know the English language or the culture of where he went, and he didn't bring any family members. But with me, it was 2017, which was not very long ago. I can say that it was very, very different from my experience. Because I work at the health center, I'm like anybody else, like in the community. Like I wasn't treated like differently because I work here, and because it was 2017 at the time, and I still, up to this day, I don't know where I got it from. Probably one of the patients that that come here, but anyways, I was I had a little bit of like a chest infection, and turned out it was pneumonia. And of course, because they um, they do testing just in case I don't have TB. But so the call came in when I was home. I said, and the nurse said, you're tested positive for TB. And everything came to me, and oh my gosh, I was in denial. But of course, I was going to get the treatment here because they can now do treatment here. We don't have to go south. If we have to go, we have to go just 2 hours by airplane to Iqaluit Hospital. But with the TB treatment, they started here, and because of the toxicity of the medication, I had to be sent down to Iqaluit for a couple of weeks, for 2 weeks, for isolation, and to my liver toxicity to be monitored. And it was a trying time, but a year before that, there was a lady who was diagnosed with tuberculosis who lived in Iqaluit, and because this lady died of the TB pills, was toxic to her liver, and I was getting the same. And I'm very grateful that that because of her, that I was sent down to Iqaluit to the hospital, just in case my liver got worse or something like that. I wish to always think to the family of that person who died, and I actually talked with the doctor at the time. The vigilance of the healthcare system saved my life, actually, because of what happened to that person. And I wrote a letter to Nunavut News at the time, I guess. I just found that. But yeah, it's very, very different now. I got through it. The only thing was that because it was DOT, I had to come to the health center every single day to get my medication, because outdoors person, and I don't like to be here on the weekend whenever I can. But I had to be in town in order to have my medication for what, 9 months? I think 9, 10 months. I think it was 10 months. Yeah. Um, I got through it, but still, I was with my family, which is good. Minus that 2 weeks I was in the hospital for isolation in Akarit. But yeah, it's very, very different. And you talk to in your own language. You talk to your family. Whereas in my husband's days when he had the TB as a child, like I guess he didn't talk to, well, there were some other children that had TB from other communities, but he didn't have his parents or his siblings or anything like that. But I had my family when I had it, and it really helped me in my work. I can say to the community, you have to be vigilant. You have to be competent with your medication, because look, your ancestors, your grandfather or your sister, they had to go down south, not see their family at all, or even call, or even telephone. Don't know when. So this day, when I talk about TB treatment, and when I talk about TB to my fellow Clyde River people, I always say, look, you are so lucky that you are going to be with your family, your language, your food. So it has really helped me in a lot of ways. I got through with it. Takes time, but it's good. Um, Anything else I can? um, yeah, I, yeah, I wrote this with CAN when I was with CAN. At the time, it was Canada Aboriginal AIDS Network. They do a lot with tuberculosis as well, and I wrote this, and they probably have it. So if anybody wants to take a look at it, they're welcome to. Thank you. Kuyanamik.
Kuyanami, Aiga, thank you so much for sharing your experience and also your husband's experience, and that comparison between the way things were done and the way things in some ways have improved, although there's more to be done, but really appreciate you sharing that.
Yeah. And I'm grateful for ITK, very grateful that they're doing the Namilagut. Let's find them. And Kelsey, thank you for the history. Thank you. Kuyanamik.
Thank you, Aiga. Our final presentation today is from Tina Campbell. Tina is an Indigenous woman of Cree ancestry from Treaty 5 territory. She lived the majority of her life in Iqaluit, Nunavut, and this is where she started her career in public health at a tuberculosis clinic. She has more than 12 years of experience working in various roles in TB programs, as well as working in different Indigenous communities. Her frontline experiences are what have shaped her into advocating for cultural competency training for healthcare practitioners that work with Indigenous populations across Canada. Currently, Tina is the tuberculosis advisor for Northern Intertribal Health Authority, an organization that works with 4 tribal council partners and 33 First Nation on-reserve communities in northern Saskatchewan. Unfortunately, Tina was not able to join us in person today as she is traveling in her role as Stop TB Canada co-chair. So she has prepared a recording and I will share that now.
Hello, thank you for the introduction. My name is Tina Campbell. I'm the TB advisor at Northern Intertribal Health Authority. I'd like to acknowledge that I live and work on Treaty 6 territory, the homeland of the Métis. I pay my respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Just a quick outline of what I'm going to be talking about today. I'll do an introduction, just talk a little bit about my work experience and my experiences with TB, introduce Northern Intertribal Health Authority, talk a little bit about the 7 good practice statements, our NATHA TB program, our program initiatives, and talk about some successes, challenges, and recommendations. So as I said, my name is Tina Campbell. I've became familiar with tuberculosis when I was diagnosed with latent TB infection in 2010 during a mandatory screen for nursing school. A couple months later, I was actually offered a summer student placement at a local TB clinic. I had no idea that TB still existed, let alone that my community had a clinic dedicated to TB care. I then became a registered nurse in 2013, and I was offered a position as a public health nurse where my main role was TB clinical coordinator. I did case management, screening, and surveillance. I also did some immunization programs and also helped with the sexual health clinic as well. I also did relief TB nursing in other remote communities in Nunavut. I worked as a TB educator as well, where I offered orientation and education to current and new staff within the territory. And since 2019, I have been in the role of the TB advisor at Northern Intertribal Health Authority. So in addition to my personal experience being diagnosed with LTBI, I also have family members who have attended TB sanatoriums. So this picture is actually my grandmother in the 1950s at Fort Capel Sanatorium. So partnership in health delivery, Northern Intertribal Health Authority, our mission, we're a First Nations driven organization. And the partnership is a source of collective expertise and culturally based cutting edge professional practices for Northern health services in our partner communities. Our vision at NITHA is that our partner communities will achieve improved quality health and well-being, with community members being empowered to be responsible for their health. So NITHA is comprised of 4 partners and is the only First Nations organization of its kind in the country. We serve 33 First Nations communities in northern Saskatchewan with a population of 55,000 and growing. So our partnership consists of Prince Albert Grand Council, Meadow Lake Tribal Council, Peter Ballantyne Cree Nation, and Lac La Ronge Indian Band. So NITHA provides third-level services to Northern multi-community bands and tribal councils. These services are delivered directly to second-level partners and include disease surveillance, communicable disease control, health status monitoring, epidemiology, specialized program support, advisory services, research planning, education training, and technical support. Our second-level services are provided by the Northern multi-community bands, tribal councils to first-level communities. And second level provides supervision of staff at first and second level, clinical support, consultation, advice, and training. And of course, first level services are provided in the community directly to the members. Our TB program falls under NITHA's public health unit. And NITHA, the TB program, while they offer third level services, we also offer first level services because we provide contact investigation and assistance with community TB programs. So our NITHA TB program provides support to our partner communities by working quickly to identify and screen and refer for preventative treatment for people who have been exposed to someone with active TB, educating communities about TB, its symptoms, the factors that increase the risk of developing active TB disease, and the importance of seeing a healthcare provider early, supporting the TB program workers and community health nurses to administer direct observed therapy and to support TB programming in the communities, working in partnership with Saskatchewan TB Prevention and Control and other stakeholders to develop and implement effective strategies to work towards TB elimination. We have a huge collaborative team. We have Indigenous Services Canada. We have a regional TB coordinator for Saskatchewan region. We work closely with, and TB Prevention and Control Saskatchewan, our NITHA TB program, and then of course the community TB programs. So just a picture of our rates here in NITHA. We're on top in the yellow or the yellow line. You can see that our rates are significantly higher than Saskatchewan, which is in the orange, and then of course below is the rest of Canada. And these were retrieved from TB Prevention and Control Saskatchewan. And just on the left there, you can see the comparison between South Saskatchewan rates and Northern Saskatchewan. And then on the right, you can see here that Canadian-born First Nations are half, and then the Métis-born Canadians. So it's over half of the population of Saskatchewan that is diagnosed as of Indigenous ancestry. And why do we see these continued high numbers of TB in our communities? A number of factors contribute to this, and of course, inadequate housing, poorly ventilated units in these remote communities, crowded living conditions. Sometimes we can see up to 20 people living in a 2-bedroom house. Food insecurity, the cost of food is high in these remote communities. And often, fresh food is hard to come by. So people opt to get processed foods. They tend to be cheaper and last longer. Stigma, of course, historical TB control practices in Canada have contributed to stigma and discrimination towards those with the disease, as well as fear and mistrust of the health system. These individual and system level factors result in delays in TB diagnoses, ongoing transmission, poorer outcomes, and lower treatment completion rates. Children are especially vulnerable as they are more likely to develop disease once infected with the TB bacteria and to experience life-threatening conditions such as TB meningitis. And of course, we have access to healthcare, which is also can be a barrier to TB care. So as was introduced on Chapter 12 of the Canadian TB Standards on the 8th edition, we have the Indigenous chapter, which provides 7 good practice statements. And I have them listed here. I was initially going to go through all of them and kind of provide what our organization does. But instead, I'll just go over all of our amazing stuff, and everything kind of ties together. So our TB program goal, of course, is to have early detection, diagnosis, and treatment of TB. We have a high incidence strategy, and how we identify these communities is one definition is we have 2 or more cases in the current year. And from this definition, we've had 7 high incidence communities in 2022 identified. Part of our high incidence strategy includes community engagement, enhanced case finding, enhanced contact tracing, use of targeted screening, enhanced general awareness and education, improved occupational health, health determinants advocacy. And health determinants advocacy can look like scheduling appointments according to the client's needs as much as possible. Of course, taking medications to the clients in their homes with our DOT program. And also visiting clients at home while doing investigation interviews and getting more information that way. We have we use social network investigation, and I'll talk a little bit more about that in our next slide. The NISA TB program as well took part in an LTBI mobilization project back before 2020. Before COVID came, we were offering that in our communities, and this is where we were identifying LTBI and offering preventative treatment. We also participate in the TB Pathways project with the Alberta team. And this, we had currently in one of our communities, we have a advertised post for a TB program worker, a community engagement worker that we're hoping to fill that position. Unfortunately, we haven't had anybody apply, but we're still looking for somebody to assist with awareness and education in the communities for that project. We have rifampicin 3-HP availability for our clients on latent TB treatment, and that reduces the treatment time, of course, down to 3 months, as opposed to the 9 months that I took back in 2010. We have Gene Expert machines in our communities and portable X-ray units. We have 2 of them with our program. Our TB program workers, we are very lucky to employ TB program workers in our communities to offer that continuity of care. They are the link between the client and the TB care team. And they're able to provide care in their Indigenous language, which is really important. Of course, we have an incentive program as well. It's a huge success with our program. Sometimes we offer, food vouchers and other items to meet for people to encourage people to meet a certain level of compliance with their medication. We also provide water, food, snacks, because the medication, of course, that is hard to tolerate for some people. And sometimes, small children are extremely challenging sometimes to give medication to, especially 4 antibiotics at once. So we offer, small toys with each dose if we're having those challenges with them. So enhanced contact tracing, talk about social network investigation. So an evaluation of a previous TB outbreak in 2018 exposed 3 gaps in outbreak management, which included 2 incidents of delayed diagnosis, challenges in treatment compliance with past and present cases, as well as difficulties in achieving TB awareness among clinic staff and community members. The outbreak also revealed successful outbreak management activities. These included outstanding case finding through social network contact investigation, prompt diagnoses, testing, and treatment, collaborative efforts to increase capacity at the community level, excellent communication among key stakeholders, and consistent client management and medication deliveries by the TB program workers. So it was recommended by this outbreak to continue to use social network analysis for case detection activities. And future outbreak management activities should also strongly consider the immediate increase in community capacity. So I just wanted to show this slide because it shows how much of an impact our social network analysis or investigations have in our communities. As you can see, in 2022, contact tracing made up a majority by far of our of how we identified our TB cases in our communities. So our TB program back in June of 2022, we held a school screen for a certain age group in, I believe, as a high school. We provided a community awareness event where we provided lunch. It was a lunch and learn. So we had a presentation, and we had, the community had the opportunity to meet the collaborative TB team. We had our Beneath the TB nurses, myself, we had Indigenous Services Canada there as well. We did plan to send TB prevention and control, but flight availability became kind of a roadblock there, which happens a lot when we're traveling into our remote communities. Of course, this was really successful. We've seen 45 children with this screening and 3 adults. And our portable X-ray we brought in with us as well, and we had 15 chest X-rays completed from the school screening alone. And then we are able to offer 30 additional outstanding chest X-rays to be completed for the community. Prior to going in there, I believe the health center had told us that they were having difficulties getting people in for X-rays because people had to actually travel about 20 to 30 minutes to a neighboring community. So we just seen how effective that was to bring the services to them. And of course, our organization does do research projects as well. And we ensure that we follow a very detailed code of research ethics when reviewing or proposing any type of research in the communities. We ensure that the agenda is community driven, providing the research team to do a community scan to identify the needs of the communities. We ensure that we hold a very high standard of ethics given the historical events between Indigenous people and others. Creating an ethical space where Western perspective and Indigenous perspectives are equally understood is very important as well. And also incorporating and accommodating elder involvement throughout the duration of the project is encouraged as well. And just on the slide here, I have 10 important ethical research guidelines to follow. Of course, our program offers direct observed therapy, which is the treatment standard. Of course, it requires a lot of resource and time and a collaborative effort. It's extremely important too, as a TB care provider, to remember how much a TB diagnosis can change somebody's life and impact their activities of daily living and even their social circles and their family relationships sometimes. Some people may experience stigma while they're on treatment, loss of relationships, and also deal with other people's negative perceptions of TB. So that's often hard, but once you develop that trusting relationship with the client, everything gets a lot easier after that. And of course, our incentive program. A lot of people misunderstand our incentive program, but with education and understanding of the reasons why we use them, people are more willing to understand. And so with our TB program as well, we do offer education and orientation, and this goes on yearly. We have various healthcare workshops providing education on TB and the historical treatment of Indigenous people in Canada. I usually provide presentations as well if somebody reaches out. I also do have, I'm a co-chair of Stop TB Canada, which is a network of advocates. So I actually do a lot of these presentations as well in that role. So we discuss in these presentations current status of tuberculosis. Also, discuss the similarities that I've seen throughout my experience working in various Indigenous communities. So of course, at NIFA too, we can place recommendations that healthcare workers going into our communities take cultural competency and awareness training along with TB training. However, it remains up to our partner organizations and their community health centers to implement mandatory training. We have 33 communities. We're not able to, know when somebody new is going into the community, so it's up to the partners to let us know that. The NIFA TB program does receive requests for education and orientation, and this is often provided to nurses going into the community. And a lot of the time we provide orientation, a nurse goes into the community, unfortunately does not go back. And also incorporating job interview questions, asking those applying what they know about the historical treatment of TB and the Indigenous populations and how this could change the way they provide care. So that's an important question to ask for us as well when we're hiring somebody into the TB program. We have high school educational toolkits. We have TST training kits. So we have these rubber arms that we can use, and they kind of show how a TST and what an induration would look like. We also have some resources for TB in children, and we have a nice video too on our website that's voiced by my son actually, and it's very well received by our communities. So some of our awareness campaigns, we have a NETHA TB newsletter that we provide to our communities when it's requested, and also when we're doing visits into these communities, we often bring specific information for their community or for their partnership communities. We have website and Facebook messaging, radio awareness campaigns. We actually have one that's being started tomorrow. We'll run for the next couple weeks for World TB Day, and we do those in English, Korean, Dene. World TB Day every year, we send out information packages, memos from our MHO, and promotional items to our communities. Last year, we had a World TB Day Youth Poster Contest. That was really great. We had some really excellent submissions for that. And then because of that, this year, a lot of our communities are doing coloring contests for elementary school. So we're excited to see the outcome of those as well. Youth conferences, we did a whole bunch of TB 101 sessions, and we had some good participation in those. Community health fairs, of course, and TB resources updated on our website. The picture here on this slide is 2 of NETHA TB nurses actually doing a podcast and providing TB education in Dene. So that was awesome. That was last year. And this is just a picture of the resources we have on our website. And you can see that we do have them labeled and what language they're available in. And we have a whole bunch of TB survivor stories, which are really good. Everybody should go take a listen. So our successes, recently within the last year, we've began to really update our TB data collection after we've gotten all our employees back from working with COVID. So with increased EPI support, we have created and started utilizing new databases, which offers our staff the ability to pull data quickly when we need to update our communities or our partners. Our collaboration continues and is amazing between TB Prevention and Control Saskatchewan, NETHA TB Program, and Indigenous Services Canada, as well as the communities. So without one or the other, I don't think we'd be able to function as good as we're functioning. So it's really important that we all work together. So we also provide outbreak update meetings, and obviously our collaborative effort, we identify TB a lot more with the collaboration. Our portable X-ray unit. So at the beginning, we are experiencing 3 outbreaks at the moment. The first 2 were declared in October of 2021. And unfortunately, when that was declared, our only portable X-ray unit needed repairs. So because of that, we acquired 2 units to ensure that nothing like that happened and delayed our care in the future. And in 2022, our portable X-ray units were utilized more than 300 times in our communities. Our TB nurse presence in our communities, we have 5 nurses for 33 communities, and about over half of those are providing medication for TB. So we're quite busy with our small team. And we are getting increased requests for education and orientation sessions. And we do have a dashboard on our website that offers a monthly update for our partners on any new cases that were identified. So some challenges, of course, short staffing in communities, high turnover, Some of our TB workers, unfortunately, had resigned, stating burnout and lack of support within community health center and feeling unsafe when providing treatment to clients. So our NAITHA TB nurses are, they work out of Prince Albert, so they travel to these communities and do 7 to 14 days offering assistance with their TB program. So we can't be in the community all the time. So it's really important for, leadership to enforce that mandatory overlook of the TB program in the community. Accessibility to information. Sometimes we have, challenges getting information from communities or different organizations, but of course with some teaching and education, and of course really ensuring that TB is handled with extreme confidentiality. Leadership engagement, of course, misunderstanding of the roles and responsibilities between the TB program, the community health nurse, and TB prevention and control. And also we find accommodations a lot can be hard to find in smaller communities. As well, a lot of our work is done visiting people at their homes, so a vehicle availability as well is always something that is challenging. Listening to the needs of our communities. I just have 2 quotes here that these were taken from a research project that Masters of Public Health had done for us last year to talk about the impacts of COVID-19 that's having on our TB programs. So one of them says having a full-time TB nurse would be helpful. We have been through too many casual nurses, and things such as TSTs and contact tracing are falling between the cracks. That was a healthcare professional. And then another one was reduce barriers to sending clients by medical taxi to Flin Flon, Manitoba for chest x-rays. So that's sending them to another province to get an x-ray done, which became more difficult during the pandemic. So the resumption of mobile clinics with mobile x-rays has been very important to restoring access to care in my area. So that was another healthcare professional. So some recommendations that I have, mandatory delegation of a community health nurse to support TB programs and our TB workers in the communities. Hiring of a community TB nurse should be prioritized, and a long-term plan, so at least 2 to 3 years for communities that are experiencing an outbreak. NAITHA is located in Prince Albert City Center. So an outreach program for our community members moving between our city and their community, so their care is not falling through the cracks, and they're continuing to be provided quality care. Hiring additional support for utilization of our portable x-ray. So I have a check mark beside this because the slide was made later part of last year. So we did hire another x-ray tech, and she's actually a lab technician as well. And they've been quite busy since we've hired her. So the need was definitely there. Our TB nurses obtained certification for phlebotomy as well to assist with lab collection in communities. And we're working on our TB nurses being trained in gene expert utilization and how to process those tests, so we can offer training to staff that is identified. So moving forward, continuing to advocate for our communities, access to timely care and treatment. That's one of my main, goals. Ensuring information is available in all Indigenous languages and supporting our TB program workers. Orientation, of course, offered to current and new staff as much as needed. Engaging leadership, community scans to help identify ways to provide services to communities based on location, culture, and language. Of course, offering that cultural competency and awareness component as well. Sorry. And of course, in partnership with the provincial TB program, update and incorporate Indigenous centered language and definitions into policies and procedures. And that's all I have. So thank you for having me today. Let's end TB in our communities. And that's a picture of my son on World TB Day a couple years ago. And I do have my email up here as well if anybody wants to email me with any questions.
Thank you again to all of our speakers for joining us today and participating. I'd now like to welcome anyone who has a question for any of our speakers to either type it into the chat or raise your hand. And if you're joining us by phone, please dial *9 and we will prompt you to unmute your line to ask your question. Although Tina was unable to join us today, we do have Leslie Brooks on the call. Leslie is another TB nurse with NITA's TB program, and so she's available to answer questions about NITA's TB program. So I see there's a question in the chat that I'm going to toss to Leslie. So the question is, who does DOT? Is it public health or community organizations?
Good morning, this is Leslie. Our DOT is delivered by trained TB workers from the community. So they are hired, they're identified and hired by the community, and we offer the training. So then they are the ones that deliver the medications to the clients. They speak the language, they know the community, so it's a really great program.
Thanks so much, Leslie. Okay, and another great question. Who funds the community TB workers?
So there's two ways they're funded. They're funded by contribution agreement. And so that means the money is flowed through to the partner organization and they will pay them. And then they are contracted through NITA, and they would send invoices to us and we would pay them. So there's two different ways of doing it. Basically, you know, we're funded by Indigenous services. So that's two ways of funding. I'm trying to keep my answers short.
Thanks so much, Leslie. And another one for you. Can you talk about other roles that the TB workers have? And although I'm directing it to you, I'm going to come to you next. And I don't know if you're able to speak about through your personal experience, what roles you saw the TB workers in your community have.
Our TB workers are invaluable to our program. They're the backbone of our program. We rely on them for absolutely every component of the TB program. So direct observed therapy is, of course, the priority, because having clients get to the end of treatment is the goal. So that's one very, very important role. The other important role, of course, is they are very supportive of us doing contact investigation in our communities. They know the community, they know the family connections, they speak the language. So they help with contact investigation sometimes, because we have in many of our communities very limited involvement by the community health nurse. So we and TB Prevention and Control respond directly or ask directly to the TB workers for their help. So when we are doing a contact investigation, we may not have a nurse that's available for the program. So our TB worker is the one that will start the list for us and make the connections and collect phone numbers for us to start the process before we actually arrive in the community. They collect sputums. They arrange and participate in TB clinics. They participate in the X-ray clinics. They will gather clients. They offer education. They are the absolute backbone of our program. And I don't know how we couldn't manage without them. Unfortunately for us, with the healthcare crisis and community health nurses not being available, so many of our TB workers are expected to have this huge knowledge, which they do have, but it's still a delegated program from a community health nurse perspective. The nurse is responsible and should delegate the program to the TB workers. In many of our communities, the nurses are going to the TB workers for guidance and direction.
Thanks so much, Leslie. And I'd also just like to point out that NITA has some amazing spotlights on your community TB program workers up on your Facebook page, and they're really, really lovely to read. So feel free to check those out. Iga, I'll throw it over to you from your perspective as a TB patient in Clyde River and in Iqaluit. What role did the TB workers that you engaged with play in your care?
Well, when I was in Kaluit, when I was in the hospital, the nurses didn't give me the medication. And when I got out of the hospital, I went to the the public health place in the Kaluit, and I had to go there and get my medication. But here in Clyde River, we also have a clerk interpreter who is trained to do DOT. But when we don't have anybody for DOT, then she's clerk interpreter. She's also X-ray, so and she knows the language. It's very convenient.
Mm-hmm. And a big role for
Yes,
her as well. Yeah.
yes.
Yeah.
But and people know her. She's from the community, and it's good. It's
Yeah.
good that way when people know the person. Yeah.
And I'm wondering if that actually ties into the next question, which Leslie, I'm going to pass over to you, is how is DOT received by your clients? Do they see a value in DOT services, or is DOT seen as babysitting and not required or wanted? And I'm going to add on to that do you see a difference in how people view DOT when it's offered by someone sort of from outside of their community or from within their community?
I think DOT is really well received by the community members. The connection between the TB worker and those community members is very strong, considering some of them are on medications for up to a year. It's delivered in their home. They rarely have to come to the clinic. Sometimes it's their choice to say, I have to work, so I'd like to meet you at 9 o'clock every morning. And we might try to accommodate that for the client. And we visit, it's daily visits by two, or more community TB workers that are hired from the community. So it is well received. We do a lot of education around the importance of direct observed therapy and the reasons why we do it. We don't do a lot of self-administered treatment. There is now, you can have EDOTs. So if that's something because you have to work, that can be arranged. Those are some things that have changed, but it's still a program that's very valued. That close connection that the client makes with the TB worker in the community, we identify so many other things that are going on in their lives that the TB worker can acknowledge and bring forward to those of us that can maybe offer more incentives, food insecurity, other issues that the families are having that maybe we wouldn't know about. If that makes sense, like we don't know necessarily if I might be the nurse in the community health nurse role. I'm not going to know that because I am from outside of the community. So the TB worker can identify that and bring those important things forward and say, like, this is a family that's struggling with food security, and we can offer groceries and other incentives like that, where there's no, I think there's no shame in that. Like, and it's somebody from their community. So I think that part is so very important. It's really hard for community members struggling with other issues to come to a person from outside of their community and have to admit that they're struggling with something. So TB workers are, like I said, they're everything to our program. Mm-hmm. Did I answer all those questions, Andrea?
I think so. And I'd love to hear from your perspective, because you noted when you were speaking about not being able to go out on the land because of DOT. And I'm just wondering if you can share a little bit about how that experience was for you and what the impact of that was for you.
It was hard, but the fact that it applies to all the people, it doesn't make because I work here, I wasn't expected not to listen, but it applies to all the people and the same thing. So it's fair. I got through it. It takes time, but you can go through it. Yeah.
Mm. Mm-hmm. Thanks, Iga.
Mm-hmm.
The next question from Courtney, I'm going to invite Kelsey and Alex to take this one. So when healthcare workers and allied staff are going to an Indigenous community for the first time, where or how do they learn about past local histories and epidemiology of TB as per the recommendations in the standards?
Yeah, I could take a shot at that. I think one of the best ways to learn about the past local history, especially just talking to the people you're working with. Like a lot of time you're going into health centers and there are people working in those health centers that have lived in the community. Do you know everyone in the community? They can give you like some history. They can give you connections to people who do know that history. So just talking to the people who live there, I think, is one of the best, easiest ways to learn the local history. And one of the things about epidemiology of learning the epidemiology of TB in a community is that very rarely will they be able to give you like a data set, like, oh, like this year to this year we had like TB this much, or like it went down. They'll be able to give you, I think, better understanding of the environmental situations that may affect TB, which may be more of value, especially with what the standards are saying like, oh, people are dealing with food insecurity, people are dealing with the overcrowded housing and things like that. You can listen to that from the stories, and I think that they'll know more about that than raw data sets and things like that. So yeah, Alex or Marlene, do you have anything to add to that?
I'll see if Marlene wants to go first, if anything to add, before I chime in for Inuit.
Yes, yeah, thanks for that question. I'm going to leave my camera off. I'm just having some broadband issues right now, as I do many times. Yeah, so I think I would just answer that question by saying, why wait till you're going to an Indigenous community to learn about Indigenous health and Indigenous TB? I think one of the things that you can do is go to your whoever is hiring you, your contractor. I know that ISC has some training available, and these webinars are some of those things. Yeah, just go to whoever you're in contract with to look for training opportunities and onboarding opportunities that include these types of information. Also, we're doing a lot of work. Well, I know that there is many initiatives on anti-Indigenous racism in the healthcare system, and there's the consortium of Indigenous medical education that is really working with schools of nursing, of all kinds of like medical training schools, to really look at their curriculum and to find opportunities of where to include factual First Nations and Inuit and Métis experiences with the healthcare system, so that medical professionals are not leaving with like, oh, now I got to go learn about Indigenous health, but to have it very, very much in the curriculum and training system, so that medical professionals are leaving with a toolkit and with the knowledge needed to provide culturally safe services in communities. Also, shout out to Leslie Brooks. Hi, Leslie. Hope you're doing well.
Hi, Marlene.
All right, I'll just finish off to say that for Inuit, there is a historical and governance session that was done a couple months ago with the Canadian School of Public Service that was held with ITK. And we do have a colleague, actually, I've been trying to find the link online. It was held a couple months ago, so let me dig that up and I'll send it over to Andrea for her to send it to the group. But it's a really informative discussion, as well as we have a colleague here at ITK that could be available. I'm volunteering him for something, but essentially it is his role to provide this presentation and other formats as well for organizations and other stakeholders if they require that. but the webinar that had been done previously is posted. I'm trying to find somewhere, but you can view that at your own pace as well. And reinforcing Marlene's comments that there are modules that each of the regional organizations are putting together or have put together that it is expected of trainees as well as healthcare workers to review these modules, and they are the ones that are going to have the expertise in providing the local context for you before you arrive to the community. And agreed with Marlene as well, the why wait. It is something to think about in terms of truth and reconciliation, of learning about the Indigenous peoples of the land that you tread on, that you enjoy. And there's a lot of like rich history there that is just waiting to be discovered. And some of it is tragic, but some of it is very informative of like what has shaped the ideas and how people interact with the healthcare system today. But in addition to that, I'll say some other great resources. The National Collaborating Center on Indigenous Health has a load of resources on cultural safety, to other a TB compendium as well that they have amalgamated. So I encourage you to go and view those resources there as well.
Thanks so much, Alex, Marlene, and Kelsey, and absolutely agree with why wait. Learn about it now. There's so many resources out there. I just want to highlight as well that I'm pretty sure we've got people on this call who don't work in Indigenous communities and whose primary population is not Indigenous people. And so in those cases, I think, ask about strengths, ask about experiences, and what are your expectations of me? What can I do as a nurse or a healthcare provider to help you overcome this? How can I make your experience better? And I think that goes a long way. Alex, Marlene, Kelsey, I don't know if you want to say anything about that in terms of how, if somebody's not going into an indigenous community, how can they provide sort of culturally safe care?
Yeah, and I think you hit the nail on the head there, Andrea. It's about being open and understanding your own biases before you go into any conversation. Seeing the individual as a person with their own history, their own story that wants and needs to be understood and told, and that the recipient needs to listen, and the recipient is the healthcare worker. And being open to that, like even in my own experience, like that, those have been some of the most encouraging and informative conversations in helping patients achieve their health goals. And how can we facilitate that for them? And so it's cultural safety isn't like an Indigenous exclusive concept, although it was coined by a Maori nurse in New Zealand. It has evolved and grown and can be attributed to all different populations, including refugee populations, other populations, Indigenous populations from other countries. So there's a dynamic to it, and it all goes down to the client-centered care and being open to their experiences, and how does it differ from what you are perceiving and how you are looking to deliver that care, which may need to be, and usually has to be, modified and to accommodate them. So there's a lot to unlearn when it comes to even in our like medical training, and how the dogma of what we get trained can sometimes be more harmful than it is beneficial. So yeah, but I'm probably preaching to a lot of the choir here.
Thanks so much, Alex. I see that there are a few other questions that Leslie has been able to answer in the chat. A last call out for any questions. All right. Thank you so much, everyone. We're almost at the end of our time together. And before I invite Sequalia to close our webinar, I'm going to launch our final poll and ask you to respond to these 3 questions. So I'll give you a couple of minutes to do that before I invite Sequalia to speak. Alex, go ahead.
Hi, Andrea. Sorry, I forgot to do one thing when I started acknowledging where I am. So I'm in my cousin's backyard here, the Algonquin Anishinaabe. I'm Anishinaabe from Northern Ontario, so usually we'll point with our lips
Yeah,
when we're when we're in a different in our cousin's
yeah.
territory. But I just wanted to acknowledge them, and this is where I currently live, stay. But at the same token, there was a question back to developing resource and
It
distinction
was
and space, and what does that need,
for what
or what
thing?
does that mean? I have to go further to say that it's more than just First Nation, Inuit, Métis. Even within the various groups, the distinctions, or like, you need to understand that each group is different as well internally, different dialects. So it's very attractive to trying to do a pan-regional or a pan-Indigenous approach, which usually does not hit the mark. And I think FINIP has learned that lesson over and over again. But at the same token, we learn that lesson as well when we're trying to develop resources that, even for ITK, that has to be like locally and have a specific audience, whether we're engaging with our colleagues from Inuvialuit, Nunavut, Nunatsiavut, or in Nunavik. Like, they have different experiences as well. And even from the TB rates that you saw on the slide today, really got to ensure that you're developing resources for your context and population as well, even if it is Inuit as an umbrella.
Absolutely. Thanks so much, Alex. All right, I'm going to turn it over to Sequalia to share some final thoughts and close our webinar today. And I believe you're going to close us out with a song.
Yes. Yes. I was quickly trying to answer that survey because it was blocking my screen. And then just as you said that, it disappeared. And I was like, I don't work in health, so I don't know about applying the 7 principles. And then I was trying to find number 3. No. I just want to say, Chen Kwen Mentomi, I'm grateful and thankful to all the presenters. As I said in the first survey question, it was learning from all of you and learning from your experiences and what you shared and the history. I love the one with the picture of the grandmother at the TB center, because, you know, my uncle and my auntie and several family members were in our local, well, not local, but Kokalitsa TB center. So it's good to remember that history and show that. And also, when family survived it and were able to come home, so that people have that hope that, if it was survivable and able to go home at the end of it, then, it's even more so now in this age of technology. So those are thoughts that went through my mind, and I raise my hands to all of you for your good work. I'm going to do, and I know April's here, I'm going to do Sequalia's song, Ha Squile, greeting of the day, because today's been an awesome day. So as this is my namesake song, she was a Coast Salish longhouse person, and our elders fixed it in the early 1900s when the Indian Act prohibited practice of our longhouse cultural, spiritual ways. And they fixed songs to share with people so that they wouldn't be afraid of us. And so this is a fixed song, and we've shared it since probably the early 1900s. And so Sequalia Slolum, Sequalia song, Ha Squile, greeting of the day. While I sing this song, I ask you to open your hands, take a few breaths and ground yourself, and pray for each other, your family, and those who need prayers in your family especially, and your friends and communities. not only the communities where you're from, but also the communities where you live, work, and play. That includes your work family. And then I'll just do a short prayer at the end because I'm looking at the time. Yep. Okay. Boychaka, Chin Coin Mentomi Kakakanak Chasiam, Yons Yonso, Tunoyap in Manman Squawin to Squalls to Seats, Yons Yom Equatal Chet, Manman Equatal Chet Yap Squawin, Siaya Chet Yap Squawin, Okameo Chet Yap Squawin. Asking you, Creator, to watch over all your children gathered here today and all their family, friends, and communities, where they're from and where they live, work, and play, and put a shield of safety and protection around each and every one of them, and help them with their squall and the feelings in their hearts and minds and their emotional, mental, physical, and spiritual health and wellness. Asking you, Creator, to help all our family with serious illnesses, injuries, waiting for surgery, had surgery, those who may have different strains of COVID that are out there, or RSV, or I think that's it, or this bad cough, cold, flu that's going around, or anxiety and depression. Hear our prayers for their health, healing, and recovery. Hear our prayers for all our family and friends who have traumas with alcohol and drugs, whether prescription or toxic supply, taking many. And also our prayers for all the homeless who are there because of their traumas and battles and mental and emotional, physical health issues. Hear our prayers for them and put a shield of safety and protection around them and keep them safe, and help them with their squalling, and maybe help some find the healing path to wellness and recovery with our prayers. Also hear our prayers for all our communities who may have lost loved ones and have heavy feelings of sorrow in their hearts and minds, that we hold them up as they say farewell and in the healing days afterwards, as their loved ones go to join Creator, ancestors, and those who have journeyed before us. And as I always share the teaching I learned from my late grandfather, Dominic Charlie, and my Coast Salish elders, our loved ones, they worry about us when they leave us and go home to the other side. And they worry about us because we have to continue our life journey. And they become what I call our spirit guardian warriors. And when we're having a hard day or feeling low in our squalling, they'll send signs. And it's getting to be springtime, so we'll see dragonflies, butterflies, humming ladybugs, and hummingbirds, or hawks, ravens, eagles, anything you see on the land, air, or water that lifts up your spirit when you're having that hard day and you smile and feel uplifted. That's your spirit guardian warriors. And or you find a shiny coin, many believe they is the signs loved ones nearby, or a feather or rock that fits in your hand, pick those gifts up. They were sent for you, and they protect us from serious injury and loss of life. At a lot of times when you think you were lucky, it's your spirit guardian warriors protecting you as best they can. So again, Creator, let everyone have an awesome day and evening and weekend, and see them all soon. Tama Kwetsi Snachum, those are my words. Chen Quen Mentomiop, thank you for letting me join you. And as I always share from my late son, who I lost 5 years ago, he'd say peace and love and do peace over his heart and say top left. So top left, peace and love. And I've added peace of heart and mind, love from my heart to your heart, air hugs, big air hugs with chai up yo. You all take care.
Thank you, Sequalia. Thank you so much for ending this webinar in such a beautiful way. Thank you to all of our presenters today, Kelsey, Alex, Iga, Tina, Leslie. Thank you all so much. I hope you all have a wonderful day. And I will relaunch the poll now for those who weren't able to complete it earlier. Thank you.
Take care, Andrea, and all of you. See you
Thank
soon.
you. You too.